Hi, I'm Dr. Malia Ireland. I'm the fungal disease epidemiologist at the Minnesota Department of Health. I'm here today with Dr. Jonathan Selman, an occupational medicine and infectious disease doctor with health partners here in the Twin Cities. We're going to talk about endemic fungal diseases in Minnesota. For an infectious disease doctor, thinking about infections as a differential diagnosis is a day-to-day part of patient care. Can you talk a little bit about why providers in Minnesota should be aware of fungal diseases?
So Minnesota has two endemic fungal infections. These are dimorphic fungi that live in the environment as molds, and when they infect people, they occur as spores. People are generally infected breathing the spores in, where they cause a pneumonia or lung infection, and then they may spread to other parts of the body. These are fascinating infections, and though not common, they can cause severe disease and life-threatening disease.
So is there a typical patient for blastomycosis or histoplasmosis?
So in Minnesota, the majority of cases are white men. The patients may not have any exposure history, although in some cases there can be a historical exposure, either occupationally or avocationally.
Are there any patients that might be at more risk than others?
Immunocompromised patients are especially at risk for histoplasmosis. So patients with HIV or AIDS, organ transplantation, taking immunocompromising medications, or even diabetes are at increased risk.
In the cases that are reported to me at MDH, about 70% of people with blastomycosis are actually hospitalized, which is a pretty high number, and 60% aren't tested until they're actually in the hospital. Why might it take a long time to reach a diagnosis of a fungal infection?
Both of these infections, histoplasmosis and blastomycosis, present initially just as influenza or a routine bacterial pneumonia might present. So with cough, fevers, night sweats, joint pains, muscle pains. Initially, it can be hard to diagnose a fungal infection. It's not considered in the differential. Right. It's only as that infection becomes more severe that someone might consider it, or if they've received multiple courses of antibiotics without effect.
So what can providers do to check for fungal infections earlier? Are there diagnostic tests that can be helpful for patients who don't need to be hospitalized yet but aren't responding to antibiotics?
There are a number of different tests for these fungal infections. One of the simplest and easiest is a fungal stain and culture of the patient's sputum, along with a bacterial stain and culture. That test, if the fungal organisms are seen in the sputum, it's diagnostic, although it is of low sensitivity. Culturing the organism may take up to 6 weeks. Antigen testing can be performed, but depending on the lab, it may take days. And serology can be performed, although that takes weeks.
So from my perspective, antigen testing seems really helpful because it is an easy sample to get and it comes back pretty quickly. There can be some cross-reactivity between blastomyces and histoplasma in that test. But is that still a good one for even family practice providers to think about using?
That is a test that a family practice provider or a primary care provider should be thinking about, especially in settings where a routine bacterial pneumonia doesn't explain all of the patient's symptoms and the severity of their illness.
In the data that's reported to me, 47% of blastomycosis patients have had 3 or more courses of antibiotics before they're diagnosed with a fungal infection. When should providers be thinking about fungal diseases?
Certainly the patient with severe pneumonia, the patient who's hospitalized with pneumonia, patients with immunocompromise, and a patient who's not responding as you would expect to antibiotics. A patient should not be getting 3 and 4 courses of antibiotics for the same set of symptoms.
My surveillance data shows that people who are immunocompromised or have more severe illness like diabetes are 5 times more likely to die of blastomycosis than previously healthy patients. Have you seen this in your career?
As an anecdote, one middle-aged patient I saw who had rheumatoid arthritis and was on a biologic agent had no clear exposure. She had histoplasmosis that was disseminated, and the only exposure she had was she had walked through a park, which many Minnesotans do every day without incident. The diagnosis just needs to be thought of in the differential in these cases with more severe infections or immunocompromised status.
We find that 1/3 of patients with blastomycosis cases reported to us are exposed in a county other than where they live. Are there questions that providers should be asking of their patients that might help them consider fungal diseases sooner?
So a travel history is always important, and travel history includes not only travel overseas, but travel within the state. Many Minnesotans go to a cabin up north or go to the Boundary Waters to canoe, and the northern counties in both Minnesota and Wisconsin are higher risk for blastomycosis.